Blood pressure is tightly regulated by a network of baroreceptors, hormones, and renal sensors. But a single microscopic disruption in this system can cascade into chaotic pathology, driving blood pressures to dangerous, refractory levels. In 90% of patients, this is essential hypertension. We are ignoring those cases today. Our focus is strictly on the remaining 10%, the high-acuity secondary drivers of hypertension. Specifically, we will dissect three core pathologies: fibromuscular dysplasia, primary hyperaldosteronism, and pheochromocytoma. We will navigate this material through three clinical vignettes, peeling back the layers of pathophysiology, diagnostic sequences, and the specific management traps that test your understanding of endocrine feedback loops. In these secondary cases, prescribing generic antihypertensives is a severe clinical error. Precise, targeted intervention based on the underlying mechanism is the only path to a cure. Let's begin with fibromuscular dysplasia, or FMD. This is a non-atherosclerotic, non-inflammatory angiopathy that characteristically causes stenosis in the medium-sized arteries, most often in young females. When FMD affects the renal artery, the narrowing causes a mechanical drop in perfusion pressure reaching the afferent arteriole. The juxtaglomerular cells sense this drop and stretch. Interpreting the low pressure as systemic volume depletion, they release massive amounts of renin into the bloodstream. This triggers the renin-angiotensin-aldosterone system. Renin converts angiotensinogen to angiotensin 1, which becomes angiotensin 2, stimulating the adrenal cortex to release aldosterone. The biochemical signature here is a symmetrical elevation. Both plasma renin activity and aldosterone levels are high. On physical exam, this turbulent flow often presents as a systolic-diastolic abdominal brood. The gold standard for confirmation is CT angiography, which reveals the pathognomonic string of beads appearance of the renal artery. Renin levels differentiate these two states. While an autonomous adrenal tumor suppresses renin through volume expansion, renal artery stenosis stimulates its constant release. Consider a 32-year-old female presenting with refractory blood pressures of 170/100, frequent headaches, and unexplained hypokalemia. Initiating oral contraceptives exacerbates blood pressure in these patients. Checking morning cortisol screens for Cushing syndrome, but does nothing to evaluate the renal vasculature. And prescribing spironolactone merely masks the downstream hyperaldosteronism. The correct sequence is to order a CT angiography of the abdomen to identify the vascular lesion. If you detect an adrenal nodule incidentally, proceeding directly to a unilateral adrenalectomy without localized biochemical proof is a severe trap. You are operating on the wrong organ. Identifying a symmetrical elevation in the RAS axis directs you away from autonomous adrenal pathology and strictly mandates vascular imaging. Now contrast this with an autonomous endocrine drive, primary hyperaldosteronism, or CON syndrome. This is caused by either an aldosterone-producing adenoma or bilateral adrenal hyperplasia. Aldosterone binds to receptors in the principal cells of the collecting duct. It aggressively reabsorbs sodium into the blood while simultaneously excreting potassium and hydrogen ions into the urine. This precise ion exchange generates a classic clinical triad: resistant hypertension, hypokalemia, and a metabolic alkalosis. The initial screening metric for this state is an aldosterone to renin ratio greater than 20, alongside an absolute plasma aldosterone concentration above 15 nanograms per deciliter. This clinical vignette shows a 42-year-old woman presenting with severe muscle weakness and a blood pressure of 174/102. Her lab values confirm the expected electrolyte derangements: a potassium of 3.0 milliequivalents per liter and a bicarbonate of 30. Because her adrenal gland is autonomously overproducing aldosterone, the expanded blood volume provides intense negative feedback to the kidneys, completely shutting down renin release. Choice D is the exact physiological state. Once the biochemical diagnosis is secure, the goal shifts to surgical localization. High-resolution CT imaging of the adrenal glands is necessary, but it is not sufficient. Non-functioning adrenal incidentalomas are highly prevalent in the general population. A nodule seen on a scan may have absolutely nothing to do with the hypertension. Therefore, adrenal venous sampling is absolutely mandatory before any surgical intervention. A catheter is threaded into both the right and left adrenal veins to measure the hormone concentration gradients directly.
If the sampling shows a high aldosterone concentration on one side only, you have identified a curable unilateral adenoma. If levels are high bilaterally, it is hyperplasia. Surgery is contraindicated here. The patient requires lifelong aldosterone antagonists like spironolactone. In a clinical simulation featuring a 45-year-old male with an ARR of 35 and a 1.5 centimeter left adrenal nodule on CT, an immediate left adrenalectomy is a dangerous trap. A dexamethasone suppression test evaluates for Cushing syndrome, which is irrelevant. Adrenal venous sampling is the absolute correct next step. In primary hyperaldosteronism, anatomical imaging only provides a suggestion. Venous sampling dictates the knife. Our third pathology is pheochromocytoma, a neuroendocrine tumor arising from the chromaffin cells in the adrenal medulla. Instead of a constant hormonal drive, pheochromocytomas secrete in paroxysmal surges. These episodes manifest as a distinct triad: severe headache, profound diaphoresis, and tachycardia, layered over resistant hypertension. During an episode, the tumor dumps a massive load of catecholamines directly into the systemic circulation, violently engaging adrenergic receptors across the vascular bed. This intense receptor saturation creates an absolute pharmacological contraindication when preparing the patient for surgical resection. If you administer a beta blocker first, you inhibit the beta-2 receptors. Under normal conditions, these receptors mediate vasodilation in skeletal muscle beds, providing a necessary outward pressure release. With the beta-2 receptors blocked, the massive catecholamine surge acts completely unopposed on the alpha-1 receptors. The result is catastrophic vasoconstriction, precipitating a fatal hypertensive crisis. The strict sequence requires establishing irreversible alpha-1 blockade using phenoxybenzamine for 10 to 14 days prior to introducing any beta blockade like propranolol. If a 38-year-old male awaiting pheochromocytoma resection presents actively surging with a blood pressure of 190/110 and a heart rate of 115, pushing IV propranolol to control the heart rate will kill him.
Administering labetalol is also incorrect, as its mixed alpha and beta antagonism fails to provide the sufficient, predictable alpha blockade required. The only correct action is immediate initiation of targeted alpha blockade with phenoxybenzamine. Managing a pheochromocytoma leaves no room for error. You must adhere strictly to pharmacological receptor kinetics to prevent an iatrogenic disaster. Identifying secondary hypertension requires precise analysis of the renin-angiotensin-aldosterone axis and endocrine feedback loops. For fibromuscular dysplasia, look for the young female demographic with symmetrical elevation of both renin and aldosterone, and confirm with a string of beads angiogram. For Conn syndrome, isolate the low renin, high aldosterone profile, and remember that adrenal venous sampling is an absolute requirement before surgery. For pheochromocytoma, secure the diagnosis through urine metanephrines, identify the paroxysmal symptoms, and strictly enforce alpha blockade before beta blockade. Elite clinical mastery relies on respecting the diagnostic sequence, mapping the physiology, and anticipating the therapeutic traps before you write the order.